Good evening, everyone. Welcome to our 23rd virtual shadowing session, Research in Medicine with Dr. Deborah Derricks. If you have any question regarding our program, please contact us on our Instagram at virtual shadowing or email us at virtualshadowing@gmail.com. As always, this session is going to be recorded and posted on our YouTube channel, Pre-Health Virtual Shadowing. Next, please. After this week, we have our upcoming topic, Specialty Spotlight in Pediatric Endocrinology with a provider from Puerto Rico. We have a Specialty Spotlight in Clinical Pediatrics and another Specialty Spotlight in Emergency Medicine. So be sure to tune in with us on Zoom or YouTube Live at 7 p.m. Central Standard Time. Next, please. These sessions are brought to you by our working group, composed of Reagan, Shayon, Taylor, Elena, myself, Rachel, Ani Ruth, Miriam, Rohit, and our three physician providers, Dr. Fowler, Dr. Marchetti, and Dr. Salazar. Quick interruption, to see the slides and to see the PowerPoint, you need to pin Dr. Derricks. So go into participants, search up Derricks, and pin her screen and you should see our presentation. Might help it a little bit. We will post these slides onto our Google Drive. And again, these sessions are recorded. If you have any questions regarding the assessment, please wait until the very end. We will talk about the assessment at the very last slide. And these sessions are again 1.5 hours to 2 hours. And if you have any questions, please put it in the chat and our group will collect it for you during the 2 designated times. All right, Dr. Fowler, take it away.
Well, welcome everybody. Good to have you back. Almost 1,000 of you are online on this very interesting political day in the history of our nation. So glad you could join us. As usual, our talks will be posted on our YouTube site, and we look forward to having 5,000 of you once again join us for these terrific presentations. This is our 23rd presentation, and we're so glad to have you here. We now have we have 29,950 people who've signed up through the website in 5 months, representing over 780 universities worldwide. So clearly we've touched on something that seems to be important to a whole lot of people worldwide. Tonight, we are so honored to have a very special individual join us. Dr. Deborah Derricks is professor and chair of the Department of Emergency Medicine at UT Southwestern Medical Center. She holds the Audrey and Bernard Rappaport Distinguished Chair in Clinical Care and Research. Dr. Derricks is a very special person. She's a nationally recognized leader in emergency medicine, and she oversees the emergency medical programs at Parkland Memorial Hospital and UT Southwestern University Hospitals, which together constitute one of the largest emergency medicine programs in the United States, which means in the world. Deb is an amazing person. After receiving her undergraduate degree in microbiology and immunology from the University of California at Berkeley, Deb Derricks attended Tufts University School of Medicine, completing her residency in emergency medicine at the University of Cincinnati, and where she joined the faculty of the University of California at Davis, and she became a major contributor to the growth and development of its emergency medicine programs. She holds a master's degree from the Harvard University School of Public Health. Deborah Derricks is one of the recognized researchers in the field of emergency medicine. She's received funding from the National Institutes of Health, among other sources, for research on early management of acute coronary syndromes, the influence of gender on symptom characteristics, and the utilization of cardiac biomarkers. She has been one of the great leaders in the history of emergency medicine. She was the president of the Society for Academic Emergency Medicine, where she was presented the Society's Award for Advancement of Women in Academic Emergency Medicine. She is also a senior associate editor of the Annals of Emergency Medicine. She's also one of the finest physicians I've had the pleasure to work with. She is my boss. She is my friend. And I will say, Deb, we are so pleased to have you here tonight. Thank you for taking the time out to join us. And would you please share your thoughts about a career in research? Thanks for joining us.
Well, it's my real pleasure to be here. Oh, sorry, Rachel.
Yeah, so a lot of our students are still actually having issues seeing your slides. So do you think you could potentially stop using the app that you're using and share screen normally?
I can, not really, without having to put up a different PowerPoint.
Why don't we take it away as it is and see how it goes? Let's give it a few minutes, and then
a lot of students can't really see it for some reason.
So I should be, can't they, if I'm speaking, they should be able to see me. So ask them now if I'm speaking, it should be popping me up in the main screen, correct?
It is.
So okay. Is that helping?
They can see you. It's really blurry for a lot of people.
I have no idea why.
We'll take it away anyway, Deb, and we'll take it a step at a time. For example, we can see the map of the U.S. here and where you've been and where you're going, and that's obviously what you're trying to cover here. So perhaps we'll take it away and see how it goes.
All right, interesting. Okay, so I'm Deb Dierks. It's nice to be here. I'm going to talk a little bit about the history of research, why we do it, and also kind of some things that have gone along in my path as a clinical researcher. And then lastly, what y'all need to do to kind of get involved in research in general. You know, as you can see, I've kind of spanned the US, and I got to tell you, I'm a California girl. And so when I started my journey, you know, I went up to the Northeast for a little bit, or Northwest for a little bit to start my college, and then finished out at Berkeley. I thought I'd be in California. And I think that's the challenge of med school applications, is that you never know where you're going to be. What I do know is having the opportunity to go to med school in Boston, do residency in Cincinnati. I have made great friends that have spanned the US, and I think that's been so valuable in my own personal growth. It is great to have friends and colleagues everywhere. And I think part of the thing, if I just have you kind of think about it, going to med school, get into med school. That's like that's the name of the game. And where you go doesn't really matter at the end. Do your best, meet a lot of people, take advantage of all the personal growth you get from wherever you go. Med school is fun. Some of my best friends I went to med school with, residency, the same thing. I went back to California where I was from, and then had the opportunity to go out to Texas, really because of my research career. And it was people who I'd worked with throughout my career that actually called me and said, hey, we got this job in Texas. We'd really like you to apply. And so I think it's just the connections you make through research and being in academics that has really been instrumental on my own, the fun I've had in emergency medicine and really doing research. But we're going to talk about it first, the background behind clinical research and really kind of the ugly history that we've had in the US in research in general. Why this matters to me is I've had a lot of opportunity through my career to get really involved in regulatory matters and research. So I was an IRB member. What that means is I was on what we call the Institutional Review Board. It's a group that you have to go through to get approval to do any research at all. And when I decided to get involved in that, it was really for self-serving gain. I wanted to be on the inside to figure out what I needed to do to get my research approved. And so I joined this group, and through being there, and I think honestly, just showing up at the meetings where some people didn't, I got to be a vice chair of the IRB. I then went to go on to be the director of regulatory and knowledge support for a clinical translation research unit that was at UC Davis, and left that behind when I moved to Texas. But now I have started being on what they call data safety and monitoring boards. And those are national boards that you're on. I'm on one for a large infectious disease study called the PEDAL group. And they do a bunch of different studies on infectious disease. So, and what you do is you actually have the opportunity to look at the safety of the studies they're doing and give some recommendations on whether you think the study should continue. And so at the end, I'll share some of my kind of experiences that are really hard to believe a little bit as you kind of go through, and that I've had to the benefit and the privilege of being involved with to really get to understand how rules and regulations work. So kind of when we get going on research, I really want to talk about 4 landmark unethical research studies that have gone on in the US and the world, right? So if I had to kind of study all of research out there, these are the 4 that I think really resonate on how we've done research wrong and what has been the foundation on why there's so many rules and regulations behind what we do now. Those 4 are the Nazi medical experience during World War II, the Tuskegee syphilis study, the Willowbrook study, and the Jewish chronic disease hospital study. And I'm going to go over those a little bit in depth. Now, the first one clearly wasn't in the US. The last 3 are, though, and really goes into the history in our own country that has gone on in research. And it's not something we should be proud of. So the Nazi medical experiments were well known in World War II. A lot of times it was done to really understand racial genetic differences that they had, and underlying that, they used patients, our victims, and prisoners in concentration camps for a lot of those studies. Too many of those studies were done in horrific manners, and it really led to a famous trial called the Nuremberg trial at the end of the war. It is really hard to understand how horrific these trials are. Some of the famous ones that they did, one was called the freezing experiments. What they wanted to know was how cold a person's body could be until they died. So they would put prisoners in vats of cold water. They would cool the water down until the person died, and then they would dissect the brain and learn from it. Now, the learning and what they gained from that knowledge is, we know a human can't survive at 28 degrees, below 28 degrees Celsius. So we have identified where that freezing point, probably Fahrenheit, where that freezing point is. Other things they wanted to study is the impact of high altitude on the human body also. So they would take prisoners, create an environment that went up to about 66,000 feet, and see how they did. Well, they died. And as part of that, they actually would then do autopsies and understand and look at the physiologic effects of high altitude on prisoners and on the human body. Joseph Mengele is probably the most vicious, unruly, unethical physician that existed at the time. And he got the name the Angel of Death. He is famous for doing study on twins. He would do things like inject chemicals into their eyes to see if they change colors. In one experiment, he tried to suture twins back together. So this man's whole career was really trying to do, I don't even know how you could justify them, but really torturing twins to figure out what differences can make on genetics. Now, I'm a twin myself, and so I find these awful. They resonate really well with me, and it was horrific as I read about them, but just really one of the really most unethical people in research in the history of the world. So at the end of World War II, the Nuremberg doctors trial took place. Now remember, a lot of history, doctors were actually well respected. They were kind of revered as people who would save them. So to have a trial focused on unethical experience by physicians hadn't really been done that much in the past. So they took 23 German physicians and tried them all. 16 were found guilty, right? They got 16, 7 not so much. Others actually escaped to Argentina to get away from persecution. Now, the Nuremberg doctors trial was really important and probably one of the first things that led to some sort of discussion about, if we're going to do research, we actually need to think about the people we're doing research on. So the Nuremberg Code of 1947 was one of those things. It was actually made to say, look at patients have rights, physicians have duties. And if we define that, we have to acknowledge that a physician just can't do whatever they want in the name of science. They actually have to take a patient's right and actually look at that also. And so that's really the premise of the Nuremberg Code, which is patient's right, physician's duties. Part of those were voluntary consent is essential. A patient has the right to say no. Avoidance of unnecessary physical and mental suffering, right? Options to terminate the study if they don't like it. And the creation of other safeguards need to be present. So this Nuremberg Code really was the foundation and the first time anybody had actually put in writing that patients should have rights. Huge change in our change in the trajectory of research at that time, clearly different than what they had done in World War II. So the Nazi experiments in World War II led to the first kind of documented patient right document and code that had existed in clinical research. Well, back now to the US. And as I said, totally embarrassed by how we've behaved in our past. And what I hope you understand is it's not that long ago. So the Tuskegee syphilis experiment occurred between 1932 and 1972, 40 years. The purpose was to determine the natural course of syphilis as a disease over time. They enrolled poor African-American men. Now, this time was a depression, right? So people were hungry, people were starving. US, and especially this poor area, was in financial ruin. So they promised them money, promised them cigarettes, and got a bunch of African-American males to enroll in this study. What they did then is they gave them syphilis, right? Exposed them all and continued to observe what happened to them. Now, when it first started, they treated some, and then it stopped as a depression occurred and resources and funding for the study decreased.
Deb, penicillin had just been discovered around 1928, 29. And so the treatment was available, right?
Yep, exactly. And especially the supply came back in about 1947, but they didn't give it to them, right? So we have a group of poor African-American men getting some money, getting cigarettes for their visits, right? Something that we wouldn't think is a luxury, but it was a luxury to them at the time. They weren't told there was a treatment available. They just continued the study and continued it over 20 years from the time we had a drug called penicillin available and known to be an efficacious therapy for syphilis. So what happens? A bunch die. A bunch of wives and our significant others get syphilis. And even some children are born with congenital disease from syphilis. Now, some of the awful things about this are really kind of what the doctors said, right? They just didn't really care. They would say things like, doesn't really matter, right? As we have no further interest in these patients until they die. That's one of the quotes of the physicians who participated in this. There's a name up there from Dr. Clark, who basically said it's our duty to follow these people. And Dr. Clark's going to come back later because Dr. Clark had a long history of kind of research unethical process. Dr. Heller made a statement, the men's status did not warrant ethical debate. They were subjects not patients. Clinical material, not sick people. The justification he used is they're in a trial, doesn't matter. This gentleman was interviewed and made that comment in 1976. In 1997, some of you were alive, most of you were alive. President Clinton says the United States government did something that was wrong, deeply and profoundly morally wrong. It was an outrage to our commitment to integrity and equality for all citizens. And in that statement, he acknowledges, right, this was federally funded. It chose a select group of vulnerable people, and it studied them in a way that would be viewed today and should be viewed there as really inhumane. We've had lasting effects of the Tuskegee study. Getting this African-American group engaged in research has been traditionally difficult. And I don't blame them, because they had institutional racism of galore against them at this time and really lost faith in the medical profession. The next study had kind of in that 4 most unethical research things was a Willowbrook school study. This was done in 1956 to the 1970s. The purpose was to learn about hepatitis and understand the effects of it. They studied mentally delayed children and injected them with the hepatitis virus.
I guess that would have been hepatitis A, I suppose, would you suppose?
Yep. So the study was designed to do one thing, is understand how it goes, and then to eventually what they said was to test the effects of gamma globulin in preventing the progression of the disease. So there's huge ethical issue on this, is children were deliberately infected with a hepatitis virus. Initially, they were given stool to eat. So they were fed extracts of stool from infected individuals. Later, they made it much more civilized and just injected them with hepatitis, but initially they made them eat poop. The defense they used and what the investigators said was that, you know what? Willowbrook was having an outbreak of hepatitis. They would have gotten it anyways. So by giving them hepatitis in a controlled manner, we were really helping them. And they said, look it, we followed the Nuremberg Code. We got consent. Well, let's talk about the consent they got. Parents of children at Willowbrook were told it was full, right? You can't get your kids here unless you put them on the hepatitis floor and let us do our work. So the parents had mentally ill children, nowhere in this area to send them, and the only way they could get in to a hospital for mentally ill children was to consent to participate in a research study. We're going to talk a little bit. That's not consent. That's coercion. And we have to understand the difference between the two. All right. The Jewish Chronic Disease Hospital, 1960s. Purpose: to determine patients' response to injection of live cancer cells. Who they studied? The elderly. So elderly patients who were in this chronic disease hospital, but they didn't tell them what they were doing. So they said they got consent, but they never documented it. They never told people they were going to inject cancer cell. No one had looked at the study, and the physicians responsible for the care weren't even asked if they wanted their patient to participate. The researchers said, well, you know, documentation, isn't really needed. We knew what we were doing. Said, you know what? If we told them we were giving them cancer cells, we may scare them. And you know what? We learned a ton by giving them cancer cells because you know what? It's going to reject and we'll see with the immune response and science would be advanced. So they took elderly people, didn't tell them what they're doing, and gave them cancer cells. Not something that should be allowed today. So what happened? The state of New York actually brought charges against Dr. Southam, who was the investigator, and Dr. Mandel, the hospital's medical director. They suspended the license of those doctors. And then, you know what? Said, suspension too much. You just need to be on probation for a year. Dr. Southam went on to be the American Association for Cancer Research president. Not much of a slap on the hand, not much punishment. So even though those regulatory bodies knew that it was wrong, their actions and how they handled those doctors kind of raises the question that they really didn't think anything was a big issue at all. So those are my 4. There's a couple other things that have gone on that have shaped our world and kind of the US research. Just to kind of let you know what we've also done. Another big study, not one of my top 4, but one that's definitely worth discussing is the Guatemala STD study done in 1946 to 1948. US researchers took 1,500 prisoners, prostitutes, orphans, and mental health patients and gave them gonorrhea and syphilis. They treated 87% of those infected, but lost track of about 13%. They didn't trace anybody who could have been exposed. The study was actually approved by the Guatemalan government. So they knew to ask if it's okay. But the Guatemalan government at that time was poor. And in response to approving this study, they actually received materials for research-starved institutions in return. So we gave them money. And then we also gave them cigarettes, which seems to be a big currency at this time. In 2010, the US apologized and said, we were wrong. We're going to give you $1 million to actually study research ethics. And we're going to give you $750,000 to study STDs and to fight them because we've given and spread them so much. In 2011, there was a class action filed against the US government by 700 victims and relatives. What happened to these folks? Well, Dr. Coulter, the research coordinator, said, unless the law winks occasionally, you have no progress in medicine. Said, you know what? If we don't do the wrong things and people ignore it, we're never going to advance science. And guess what? In 1943, he decided, you know what? Federal prisoners in Indiana, I'm going to do the same study, and he did it again. Dr. Coulter then went on to be a key participant in the Tuskegee syphilis study and was dean at University of Pittsburgh in the 1960s. So let's go back through history. In 1946 to 1949, we have the Nuremberg trial. In 1963, the New York Jewish Chronic Disease Hospital study ended. 1966, the Willowbrook State School ended. In 1971, the Tuskegee study ended. It wasn't until 1966 that scientists said, we got to make this different. We actually need to look at ethics before we publish. And we need a national policy on institutional review board reviews. So before studies are looked at and started, we can actually look at the ethics behind them. So I can stop and take some questions there.
All right, we have a lot of questions so far. A lot of people are just so shocked that these types of studies happened. Was it a common practice to deceive patients before ethical standards were implemented?
You know, I think the scary part is I don't think we know how many people were deceived. We know about these because I think they caught the press and someone questioned them, but the true kind of extent of what scientists did, I'm not sure we know.
Oh man. Have you seen any unethical practices and research in your career so far?
We will be going over one of those at the end, so yes.
Okay. Why do you think they continued the syphilis study even though there was already a cure?
I think because people got lost in wanting to understand the disease state, and as kind of they made the quotes, they didn't view those people as patients, they viewed them as research study, and in that manner felt no obligation to treat.
Oh man. So a lot of students are interested in research and want to pursue it in the future. What can students do now to combat like unethical research or potentially in the future?
You know, I think that's part of writing the IRB and realizing that any study you participate in really should be reviewed for conduct. And that's even anything that's just done in a manner of what we call performance improvement, which is to make things better for patients that really isn't research, but you implement it. And so really asking your faculty you work with to make sure that that has been done. And then also if you're going to be enrolling, understanding the study itself so you can actually inform patients on what their risks are.
Awesome.
Hey, Rachel, if I may, there's been a lot of different variations on this same question. What do we do with the information that's gleaned from these highly unethical studies that's still considered science, but the way that it was achieved was certainly questionable? What do we do with that information going forward?
For example, now we know the natural, or at least in part, the natural course of syphilis. What do we do with that?
You know, I think, you know, the sad part is that, you know, Ray, Brandon and stuff, we know those symptoms of neurocognitive syphilis and what they present with, we learned in part from this study. And so, you know, I know and how it was obtained and know how awful and horrific what practices were in place. I can also, though, recognize that at the benefit of having some of that knowledge, I just really wish it had been obtained in a manner that doesn't turn my stomach.
We've had a lot of other questions too. So a lot of our students want to be doctors and they also want to do research. Do you have to have an MD/PhD to do research as a physician?
No. Typically, you have to be employed by the hospital or the institution that you're going to do research at. And so it can be a bachelor's, it can be a master's, it can be PhD, you know, PA, APP, all those aspects. The regulatory steps you go through, though, are the same irrespective of what your degree is.
Cool. Was it the history of clinical research that made you go into research or really explore research?
You know, it wasn't. I didn't really get to know this until I got on an IRB and institutional review board and understood why some of these practices are in place and how important they are to understand and to use them to protect our patients. My desire to do research, honestly, wasn't my spiel going into med school. Wasn't interested in necessarily emergency medicine. Definitely wasn't interested in doing research, but was given the opportunity when I was a resident to do some research and quickly learned that I like asking questions. I'm that person that, I love if somebody tells me this is the way to do it, to ask why. And in medicine, there's a lot of reasons that I'm not sure there's a great why out there. And so truly understanding and thinking about ways to answer questions and provide evidence so we can actually treat our patients in a effective way is really what drives me and makes me excited to do research. And I really just like answering the questions. And I think to me, that's what makes research fun is I feel bad for the residents who work with me on shift because I can turn anything into a research question. If anybody asks a question, I'll be like, that's great. That'd be a good research question. And this is how you would do it. So to me, I just take a lot of enjoyment in answering the questions.
Awesome. And so is there any limitations of what you can do in research if you don't have a PhD or if you only have an MD?
No.
Okay. Can PAs do research?
Yep. PAs can do research too.
Cool.
So the limitation to doing research is having the money to do it, if it takes money, having the time to do it, because it always takes time, having the idea, which is the hardest part, and then having the perseverance to get it completed.
Do you have any advice for anyone who wants to pursue research right now or are thinking about it?
I think you really, before you go into it and decide that's your career, I would suggest trying it. It's not for everybody. It can be tedious. It is not glamorous at all. Sometimes it is sad at times. It is rewarding at times. And it can be disappointing because sometimes other people don't think what you've done is that big a deal. And so getting it published can be challenging. So research is not for people that can't take disappointment because there's a lot of it. And you have to be willing to bounce back from it and to keep going and find a home for your papers or, figure out when things just don't work and you just aren't going to get the answers you want.
Is there any advantage of having a PhD for doing research?
I think PhDs are really important if you do basic science research. I think that's essential to get funding in basic science research to have a PhD. I don't do basic science research, so it would make no difference for me to have it or not. Same with a PA, a nurse. Typically, they don't do basic science research, so the PhD doesn't add as much value in that setting.
And then, how was your experience as a woman in a male-dominated research environment?
Yeah, I haven't found my sex to be a problem at all. I think it's more what I've done to to move my way, which is I kind of follow a couple rules, and that's if I say I'm going to do it, I do it. If you ask me to have it done by a certain date, I have it done by a certain date. And I'm gracious and I like the people I work with. And so getting stuff done when you say you're going to get done is not necessarily a common trait. And so by doing that, it was not hard at all being a woman in a clinical research environment that's male dominated. It was, I had just an equal seat at the table as anybody else.
I'm glad you did, or you still do. So how do you deal with the stigma that only successful research gets funded?
So I think the funding is really based on, it's federal funding. Not all research that's funded is successful. Good research ideas that people believe in and believe that can answer a question, either based on good science behind it and rigor and a track record of doing research, it's what gets funded. We need to publish negative trials. Matter of fact, that's one of the biggest criticisms of kind of our medical profession right now is we don't publish negative trials because they're negative. But those are also important to publish. And those are what are really hard, almost harder to get published because no one really thinks they're interesting. But negative, things not working out, that's also relevant. So nobody else repeats it in the future.
A lot of students are still shocked that we had such a negative history of unethical research. Did anyone try to stop that unethical research like earlier on, or was it just, when it got published in the news?
So it's hard to say. I don't know if they did or not. It's really difficult. I haven't found through reading names of people who vocally tried to intervene that would make kind of history books at this point.
So what checks and balances does medical ethics have in place to prevent something unethical?
Well, that's the second half of the talk. So
I think I'm excited for the rest of this talk. I think the students are excited for the rest of this talk. So I think we can move on.
All right. So the response to these abuses, right? So we know about the Nuremberg Code from the Nazi atrocities. There's one other study I want to mention because I think it was important, and you all may have heard of it, and that is the thalidomide disaster. That thalidomide is a drug that was given to pregnant women to kind of combat nausea. And it did, except for it caused birth defects. And so for a period around the 1960s to probably early 1970s, there were women who were given thalidomide for nausea and ended up having babies who had limb deformities in particular. And these women were never told, that the drug was actually investigational. They were just told we have a drug that works. And so that actually also led to the FDA, Federal Drug Association, really actually for the first time creating an act to address drug use too. And so thalidomide, although wasn't as atrocious as some of the other things, really hit the public hard because they'd show pictures of deformed babies. And so that really also brought a ton of public kind of response and knowledge to some of the research going on. And so brought a lot of press to some of the areas because these were regular women, right? These studies weren't done in groups that people could dismiss. They were done in everybody. And so even institutional bias and racism couldn't excuse it. So thalidomide itself had an impact. They just weren't told it was a study. So after kind of 1964, the Declaration of Helsinki was created, and we're going to go over that because that was one of the other foundations that built on the Nuremberg trial that was really done in response in part to the Willowbrook and the Jewish hospital. The last thing that came out after the Tuskegee was the National Research Act. And that really instilled some core principles that as a person who reviews research to be approved, you had to look at. So we have the Nuremberg, we have the FDA's code, we have the Helsinki Declaration, and then we have the National Research Act, all kind of a response to the atrocities that had gone on. So the Declaration of Helsinki, it addressed some core principles. It addressed patients' right to respect, self-determination, and informed decision-making. And it said the investigator's duties, primacy of the subject's welfare and ethical consideration should take precedent over laws and regulations. So the investigator, even if someone doesn't say explicitly it's wrong, has to have some idea that ethics have to come into play. It also allowed surrogate consent, which means if someone is unable to consent because they're too ill or don't understand, that someone else can consent for them. The National Research Act was, again, because of Tuskegee, went into effect in 1974 and mentioned some basic ethical principles that should underline all research, biomedical, behavior, anytime there's a human subject. And it had a name called the Belmont Report. Now, the Belmont Report is what every person who does research has to know about. And we have to study it, and there's some kind of forms we have to go through and training, and it's all built around understanding the Belmont Report. And that is really what's the difference between clinical practice and research. What are some basic core ethical principles, and how do we apply them on the research we do? One of the things was that practice, so the actual practice of medicine and research, are absolutely different. One should be based on standard of care, so what we know is best, and one stretches and questions and advances what we think standard of care is. An institutional review board has to know the difference and distinguish what's standard and what's not, and what's research. And we actually need to make sure that that's clear to patients when we do it. So the three key components, though, of the ethical principles are respect for persons, beneficence, and justice. Respect for persons really goes around people are individuals and should be treated as such. And if they have limited capacity to make decisions, we need to protect them, and there needs to be protections in place. Beneficence is the same thing. Do no harm. Maximize benefit, minimize risk. And then justice is, we need to ensure that everyone who could benefit from research should be able to participate. So respect for persons. This is really sometimes hard and actually raises some controversy. You need to treat individuals as a person who is capable, knowledgeable to make their own decision. That sometimes is hard for doctors to do, especially if they think and believe that what they're doing and their research is good. We need to protect also people with limited capacity, even them to the point of saying you should not participate. And we actually need to reassess that capacity in people. Now, capacity is really the ability to understand. And this is where mentally ill patients get involved. This is where depressed patients get involved. This is where mentally ill patients get involved. This is where patients, elderly, dementia, or too sick to make their own decision are included. And that capacity can change throughout the disease process. It can change with time if it's a longitudinal study. And so the respect for person says, look, you just got to keep revisiting this though. You've got to reassess it, and we want to know how and why and when you're doing it. Beneficence. The IRB should determine whether the risks to subjects are reasonable in respect to the potential benefits. And as a member of an IRB, we spent a ton of time talking about this. So one of the things that the researcher now has to do is list the risks. They had to inform the patients as risks. For me, I do a lot of biomarker studies. So my risk of most of my studies are needle puncture, right? Bruising from a needle. If I'm not going to tell patients the benefit, I have to tell them there is no direct benefit to you, but the results from this study may help the future. So part of an IRB and part of that consent process needs now to include telling people what could happen to them. And some decision about whether that long-term benefit and risk profile is equitable and appropriate. Justice, treat people fairly. Don't exploit those who are readily available or malleable. I'm going to show who we think are vulnerable patients. But when you talk about do not exploit those who are readily available or malleable, they're talking also about students, right? You as a group are at risk. You could be exploited. Your professor says, hey, come participate in a study. You know what? May not be appropriate. So we have actually a lot of scrutiny that goes in to research that involves students, trainees, anybody you supervise, to make sure that they're not being exploited. And the last point is fair distribution of the risks and benefits based on the problem under investigation. And that really is meant to say, look, we have to include everybody at risk in our studies. It's why we can't use language as an excuse to exclude people from research usually. It's why we actually can't exclude by race in most studies now. So we actually can, if a disease is common in a broad-based population that's diverse, we have to include everybody. Application of these principles is tough, and we do it in a couple ways. We have the informed consent process that all these are listed in. We discuss the risk-benefit ratio, and we actually make them specify who is going to be a target for a study when it's done. So who are the people going to be selected? And those are the ways we address a lot of these issues. So members of the institutional boards, like I was, really have to consider all these things. And I got to tell you, these discussions usually can go on for hours. They are long discussions sometimes, especially if it's unclear, if you don't understand fully exactly what they're going to study, or it's going to involve a vulnerable patient population. Another patient population that we consider vulnerable right now are prisoners. So prisoners also are in that group that we really have to have extreme caution of whenever we include them in research. So respect for person, self-determination, no coercion, right? What does coercion mean? It means I'm going to make it such a good deal for you to participate that you're going to say yes no matter what I do. And that can be done by a couple of ways. That can be done by me promising you something. If you're a student, I'm going to promise you a good grade. That's coercion. It can be done by me offering a ton of money, right? So if I'm going to pay you an amount that seems unreasonable for the time you spent, that could be viewed as coercion. So everything's got to be voluntary, and people should be able to make decisions to participate without external forces going on. Now, when I was a med student, I participated in a research study. I got $900 to do a right heart cath. And at the time, that $900 was my flight home. And so the IRB clearly thought it was reasonable as far as what I was doing to get paid. But in a way, the money is why I did it. I didn't really care about the science. It was more the money. And so in a way, you could consider that coercion at that time, where I was making my decision, not really based on probably thoughtful, thorough discussion around the risk benefits, but I needed airfare flights for my husband and I to get home. Violations of respect for persons, again, offering large incentives, not telling people what you're going to do and collect, misinforming people about the true purpose of the study, right? Those things can happen, and sometimes it's okay, usually it's not. Beneficence, freedom from harm, freedom for exploitation, and again, looking at the risk benefit for every study we do. Harm, not knowing anticipated events, temporary discomfort is how we categorize these. These are all how we look at them. So you know what? Nothing out of the ordinary is going to happen. Temporary discomfort, needle stick, right? You may have a bruise, it may be uncomfortable. Level 3 is unusual levels of temporary discomfort. 4 is permanent damage, and 5 can be certainty of permanent damage. I've never seen a category 5 be approved. But risk of permanent damage can be if the risk of the disease is such that without treatment or any study, that patient will die. And so there are some ways that we do some risky stuff under an IRB. It is hard to do though, and are carefully scrutinized. Exploitation, we won't use information against people. Some examples of that are, we're not going to enroll people with illicit drug use and HIV status and say, look at you, I'm going to tell your employer, right, if you're HIV, to get them to participate. And then the relationship should remain professional. And this really is kind of a theme that is kind of gone through medicine itself, is that we really need to separate learner, teacher, researcher, participant, and make sure those relationships are always professional in nature. Justice, treat people fair, right to privacy and confidentiality. So those we think have diminished capacity are minors. They can be people who are elderly. They can be people who are mentally ill. There are definitely groups that we link, and they're all on here. What you really need to know about it is there are groups that just we think are high risk for being taken advantage of. And again, minors, prisoners, mentally ill, institutionalized are those groups of patients that we look really hard on at when we look at their studies, and students are in this group. So have we learned from the past, right? A lot of those studies I showed you were before 1970s, right? Most of you weren't even born. All of you weren't even born, except for the old farts. So in 2009, right, not that long ago, 2009, a government office goes undercover. And what they wanted to say was, we have all these rules in place. How are they working? So they did two things. The first thing they did, they created a fake IRB, right? And said, hey, send this to this IRB that doesn't even exist, to some pharmaceutical companies. And then they created a fake device company and sent a research proposal to an IRB, thinking that as part of due diligence, as reading some of the information, someone should question whether these existed or not. And you know what? No one did. So they've got all these rules and regulations, but what they found is that even though they had these in place, there were loopholes and there were ways to get around it. And there was a way that people didn't have to go through all the checks and balances. And so about 2009, they ratcheted it down again. More protocols, more oversight, and really kind of increased the scrutiny on the IRBs themselves. But the other thing that happened because of the implementation of an IRB, and the fact that what this did was it made drug companies, inventors, innovators go through a longer process to get approved. We saw something called the globalization of clinical trial, and that's especially when we talk about pharmacy. And what we see is that pharmaceutical companies said, you know what, US, you are way too difficult. We're going to go somewhere else. We're going to go overseas, right? And so instead of taking at-risk US people, we're going to go to India and enroll at-risk poor Indian people, because we can do it easier, faster, and more, and get our answers quicker through that. And you know what? This is from Scientific Grounds. It was presented and talked about the FDA. And what it says here is, you know what? Maybe going overseas is the answer. We can do things cheaper by going elsewhere to do our research. So instead of going through and trying to get through the studies that we had in the US and the process that we had in the US, the answer to the industry, the pharmaceutical industry, would say, I don't want to wait that long. I got billions of dollars at risk. I'm going to go somewhere else. And that's where I can get my research studies to look at pharmaceuticals. So I can do that. And what we saw over the years, if you look at from 1990s to late 2000, and the number of trials done overseas, exponentially increased as the rigor and the requirements for doing research in the US increased also. So what we came to is about 80% of drugs are now approved based on data from foreign clinical trials. Over half of clinical trial subjects and sites are not in the US. And 1/3 of trial investigators are now from foreign sites. So we have pushed a lot of companies, a lot of clinical trial design outside of the US to escape some of the rigor and the time it takes to get things done in the US. It reduces cost, speed, and regulatory burdens. But it also led to some more unethical principles. So in 1997, there were 9 US government-funded studies of pregnant women in Africa, Asia, and the Caribbean. Half of those women in these trials were treated with AZT, a therapy known to prevent HIV transmission to a fetus. The other half received placebo. Why were these done outside the US? Because at this time, AZT was known to be an effective way to prevent the spread of HIV to fetuses from HIV-infected moms. And so what they said in this write-up is, look at, you know what? The US trials that did it, there were 2 that looked at the same thing, but everyone could get AZT. The foreign studies used a placebo. So what we show and what they collected from all these studies that were done out is that exactly what we expected and should have been expected occurred. That women who got AZT, their babies did not get infected, in the red, and women who did not got placebo had a higher rate of transmission of HIV from the pregnant mom to the fetus. Couldn't be done in the US because the US would say no, because you're taking a known standard therapy and denying it to people, which cannot be done according to the Belmont Report. Again, going back to look at overseas is our solution. Another issue that came up is denying the use of surfactant, which is a drug that was given to babies to help their lungs mature if they're born prematurely. We couldn't do those studies in the US because it was standard care. So they went over to some areas where it wasn't and did a randomized trial to really determine the magnitude of difference between those who did get it and those who did not. A study we could not do in the US. So what really needs to be done and how can we address this? There actually needs to be just a lot more oversight. We need to address conflict of interest. Who's going to benefit from a drug being shown to work or not work? And are they making too much money? And is that really what's driving some of the research? And then tying that in with some high profile third world justice causes to make sure that access to medicine is equal no matter where we live. So kind of questions on that, and then we'll go on just to why this matters to me and kind of tell you my story and what I've kind of experienced. So I already told you I've been a member of an IRB. I was a member of the IRB at Davis for a lot of years, kind of went through kind of leadership, and now I'm on some data safety monitoring boards. So I've had some interesting stories in my time. One of them was my research study. So this is NatureCore, and NatureCore was a synthetic kind of natriuretic peptide. Natriuretic peptide makes you kind of pee for better kind of simplicity. And it was given to heart failure patients. So I got a grant to do a study using NatureCore and comparing it to not giving it in observation unit patients. When I started the study, it was easily argued that NatureCore was a standard therapy. Well, I got about 6 months into my research, enrolling patients and getting things going. And 2 studies came out, and they were retrospective, that questioned whether this drug actually caused harm. And so as a result of those 2 papers, there was a lot of discussion that, you know what, this wasn't standard care and it shouldn't be standard of care. And so what I did is I stopped the study. gave the money back, right? Never completed the trial. Because I was doing research was under the assumption that everybody was going to get a medication that should help them, right? Either standard care that should be good, because that's what we do, or an investigational agent on top of standard of care, because everyone got standard of care. And once that investigational agent is no longer beneficial, the question of whether the risk of participating in this trial, in my mind, outweighed the benefit, and I stopped it. And, you know, and I was on the IRB, so I didn't even have to wait for them to look at it. I just made the decision. But it was a hard pill to swallow to give back grant funding that I had worked hard to get. And it was just had to happen. So this is headlines. SACB, UC Davis doctors infected brain cancer patients with bowel bacteria resign. This was a tough one. I knew both these guys. Matter of fact, one of them dated the sister-in-law of one of my best friends. So these people I'd seen, good guys. They were taking care of patients who had glioblastoma multiforme. And that is one of the most awful diagnoses to get because it almost is universally fatal. So they had some patients that were really at that point where there was nothing that could be done for them. They were terminally ill, no treatment available. And they had done research that showed that an inflammatory response in the brain can actually, in lab animals, in the lab setting, reduce the tumors and actually make an impact on the outcome of these patients. So they decided to talk to these patients and consent them and let them know what they were doing. So all the patients knew, and went in and put stool in the brains of these patients. And everyone died. Not unanticipated, right? They were going to die. That was the course that was going on, and there was no treatment. But they did it as standard care and didn't do it as research. And so it never got to the IRB to look at. And so it was never reviewed. The risk benefits were not actually thoroughly discussed. All the principles of the Belmont Report were not addressed. And ultimately, these two lost their jobs because of it. It was probably one of the more memorable discussions we've had. Most of all, because I couldn't believe that people would put stool in people's brains. Secondly, these doctors actually adamantly argued that they felt that the patients were appropriately informed. They argued that it wasn't research. Unfortunately, the box they brought the stool into said for research use only. And so that was videotaped and had clearly been documented. And it was just a, excuse me, a bad situation to be in altogether, and was horrible. So this is another one from the news. This is actually about 2 months ago. NIH.
Hey, Deb, can I stop you 1 second?
Yep.
You think that there was I mean, you knew these guys. Was there an element of the fact that the disease was so horrible? I mean, John McCain died of this, that they were trying
I honestly,
to do anything they could that might make a difference on a terrible disease. I
think they thought that they had a potential kind of foundation of a cure, or at least something that could mediate the disease process. They just decided to do it outside of every ethical principle. Had they done it, provided it got through IRB, heck, we may have allowed it if it, if the risk benefits were adequately explained, there was good science behind why they wanted to do it. They just went around every checkbox,
perhaps
and every kind of thing.
Perhaps an emergency use authorization from an FDA or something like that.
Yeah, so there's actually some provisions for what they call HUD, which is really kind of, as you kind of mentioned it is use for rare cases and people with terminal diseases where you have to get approval. And it really is kind of a short course for an IRB that can be done. And some of those kind of rare diseases, rare instances, they will use an alternative to an IRB approval to get that. they just didn't do it. And it hurt their careers, which is pretty sad. So this is another one. This is NIH Halt's clinical trial of hydroxychloroquine. This is recent. It is hydroxychloroquine was a treatment for, thought to be a good treatment for COVID. And this was a national trial, multi-center, run out of Vanderbilt. They had, gone through the process. They had randomized people to receiving it or not. Well done study. I served on the DSMB and was part of that group that halted it. And as a data safety monitoring board, one of the things you have to look at is futility. And what it came down to on hydroxychloroquine wasn't that it was harming people, but it wasn't helping them either. And we got to the point in that trial where there was no way, had they continued it, that it would show a benefit to patients. And so that risk benefit ratio changed because there was no benefit. And so instead of continuing a trial that was futile, the decision was made to halt it. And that was a big deal. This was a 5 p.m. Friday night to 9 p.m. Friday night discussion on really were we certain that the recommendation to the NIH was to stop it, because the last thing you want to do is stop a trial that actually could help people. And so
hydroxychloroquine actually seemed to have physiologically, for example, alkalinizing of endosomes and so forth, some compelling things that might have worked.
Yep. But this was a big decision. The NIH did, took the recommendation from the Data Safety Monitoring Board and halted it. I think, our results were also looked at, and what we had also when we made this decision were the results from all the other clinical trials that had shown that it really didn't work that well. So again, this is kind of where research goes. This is what part of it is. It's been an interesting process. There are many COVID studies that they're looking at right now that I have to make some decisions on, or at least provide my input. But that's really part of research. And that is having safety monitoring boards that are separate from the researchers. No researchers part of it. This is an independent group that's goal is to look at it. Even that, though, is not done with scrutiny. This is a letter sent to the NIH by a public group that questioned the overall kind of safety of the network that I'm part of the safety monitoring board on, and they raised concerns about consent. And so this has been going on since 2018 before I got engaged, but definitely there's scrutiny on even the overall network that and all the studies are looking at that the public is engaged with. So these are kind of my kind of experiences. I'm going to be dealing with this one for a while, but definitely really makes me appreciate what can happen, looking at why things happened, and also all the thought and the carefulness and the extensive discussions that go on when you actually evaluate the safety of a study. So on that cheery note, if you still want to do research, which I do, I think it's really fun and I love it. How do you get involved? And these are kind of my 5 steps. And my N of 2, which are my kids, it's worked so far. But these are kind of the rubrics that, we walk through trying to, when they ask the same question is, what do I do? And first is do your research. And what I mean by that is if you have an area you like, Google that department in your school, Google that department in your school of medicine, go through each of the faculty in there and look to see what they're doing. Most faculty profiles have a list of the research they're interested in. When you find one, email them and say, I have looked at your profile. You are doing work in X. Write the title down so they know you work. And I would like to talk to you about getting involved in your study. So my older daughter was interested in sports. And so she looked up a kinesiologist and got involved in some research on orange juice hydration and got engaged in that. My younger daughter, also interested in sports, emailed a sports medicine person and got engaged in some sports medicine research. The key is it may not take just one email. and you need to email again. So if you don't hear back from somebody, don't take that they just aren't interested. Sometimes your emails are in amongst of 30 to 100 people get a day. And when people are going through and cleaning your email, they may put a flag by it and just not get back to it. So email again. Once you make contact, go talk to them. And this is the hardest thing. Research is not sexy. You as an undergrad or as a high school student or even as a medical student, you aren't going to get to do all the cool stuff because most research isn't all cool. It's just fun to find answers and accept anything they want to do and they give you. It may be entering data. You can learn a lot from entering data especially if it's medical terms or anything. And that's just part of it. I enter data. Matter of fact, in the last 3 weeks, I spent probably 40 hours doing chart reviews to help one of my colleagues out because they weren't going to get it done. So anything they give you is a foot in. Take it. The one thing that'll help you get more is to continually do it. We're all busy. And so don't go into research. If you're going to get engaged, it's not a quarter thing. It's a year thing. It takes that long. And so really, if you're going to get engaged in research, make it a commitment. Medical schools like long-term commitments, right? Show perseverance. You can also get a heck of a better letter of recommendation from somebody who you've worked with for a year than somebody you met 4 times. So if you're getting engaged in research, it's an investment. It's an investment of your time, which will pay off with a great letter of recommendation and saying something that you did. And you don't have to get published. The reality is most research projects, about 50% of them never get published anyways. You do have to know what you did. You do have to know why the research is being done. So know the question being asked, being able to talk about it, be able to talk honestly about your role. Part of the med school committee, although I'm not on it now, I've been on it in the past. We don't expect you to be, the person doing everything. We understand if you're doing chart reviews. We understand if you're entering data. We understand if your job is to type stuff or to do menial stuff. That's okay. We've all done it. And so really, you don't have to do everything. So really accept anything and understand your value. You're a part of the team. You may be working for a postdoc, right? Who's got the person they work for. And it's okay. Your value is getting stuff done and helping them get their answers. And that really is what you're going to do. At this stage of the game, you probably aren't going to develop your own research study and take it from beginning to end. That's going to take time. It's going to take time to get to know somebody. And if you do that, it's because you made a longitudinal investment with the person you're working with, and you have developed that relationship where they trust you to support your own research. And so again, do research, figure out who you want to look, to talk to, and then email them and be persistent. Email them again. Make this a long-term investment, right? Doing it for a semester is fine. Doing it for 2 is better. So longitudinal showing dedication is going to get you much further along as far as getting things done, getting things published, and understanding what you're doing. And so I think those are some of the keys to really getting engaged. And with that, I am happy to take questions. Yep.
All right. Well, thank you, Dr. Derricks, for just telling us about research, and I'm sure you've inspired so many students tonight to do research. We have a lot of questions coming in. First, students want to know more about the IRB, like how do you get onto it, and like what does the IRB specifically do?
Right, so the institutional review boards are made up by members of usually School of Medicine or other people within the health system campus. There can be pharmacists on there, nurses, kind of research coordinators. Most of those people are selected to be on it. There is a community member on it also. And if a study is going to discuss prisoners, there is a prisoner representative that comes in. And so what they do is any study that is deemed to be more than minimal risk has to go through an IRB and be presented to a committee to review all those aspects of the Belmont Report. The consent, the protocol to make sure the risk benefits are there, looking at the safety and making sure that the participants are all encompassing of those who are at risk for the disease.
Awesome. And then is there someone that keeps the IRB in check?
So the person that keeps the IRB in check, there's a national office that actually kind of will come in and audit and do audits. And so and then different policies that an IRB has to go through each year to get re-credentialed. So they're kind of two different offices that look over the IRB to make sure they're following rules and regulations.
So Deb, let me interrupt with one. So you're an acute coronary syndrome heart attack research person. We know that there's some question as to whether, for example, adrenaline, epinephrine, is a benefit in cardiac arrest. But these patients who have dropped dead and we're trying to resuscitate them cannot consent. So how do you go about doing such a study like that?
Right. So about 10 years ago, the government passed something that allowed exemptions from informed consent. And that was absolutely made to address research in the area that Ray talked about, where you can't actually consent people. So those are pretty darn tough to get through. What has to happen to get a study like that through is you actually have to prepare a community awareness plan. So what you do on that is you actually take your study and you take it out to populations that are relevant to your study in general. So patients, if it's a cardiac arrest group, you could take it out to community groups that deal with elderly because they're more likely to have cardiac arrest, or just general public groups. And you inform them about your study and you give them the opportunity to opt out. So they can either email the principal investigator and say, I never want to participate in this, or not. Now that itself is not fail proof. We've had some press for some of our investigators that have done cardiac arrest research and still had it challenged, even though it was done under the exemption from informed consent, the public still will question the validity. But there are certain policies that have to go through for community awareness if you're going to do a study that is exempt from consent for the initial enrollment. All those patients who are already treated with cardiac arrest, if they survive, they will be consented and their family will be asked to consent at a later time.
I remember one time after speaking to a city council about something that Jim Atkins and I were going to work on, one of the council members came up after it. Can you make sure I get the real drug, son? Rachel?
Yes. So if you see that there's any type of unethical research or research that doesn't look like it's going to be beneficial, what is the process to stop those research practices?
So every research project has to go over an annual review. That's when a lot of those discussions are kind of brought up. The more at risk the study, the more extensive it is reviewed. It has to go back to the full committee where you look at what they've done before. You've looked at kind of what the results they've had. There is a mandatory reporting if someone has what we call a serious adverse event, and that can be either a rehospitalization or something that's already named a serious side effect of a treatment or an intervention. So those have to go to the IRB within 72 hours. So that also can cause a study to be halted or relooked at if there are too many serious adverse events. If there are not, then it gets an annual review to look for these same kind of principles.
All right, cool. So in light of the rush to develop the COVID vaccine, what precautions are put in place to make sure that marginalized communities aren't being tested on like in the past?
So most of the COVID vaccines itself are not community. They're actually, people have to be consented. I think we've seen actually the IRBs work when you saw them halted, right? So those are halted usually because of a serious adverse event. One got halted and didn't review, and that's probably because the IRBs looked at all these side effects and said, this won't go, too much risk. And so one of our companies has already dropped out. Another one restarted once some of the side effects were looked at, and they may have been deemed not related to the vaccine itself. But the current vaccine trials undergo the principle of consent. They undergo the review of serious adverse events, and they also undergo annual review.
Is that the same process for looking at like new drugs for trials?
Right. Yep.
Cool. Do you think there are any other regulations that need to be made for research that's happening today?
I think we need to be really, really careful when we look at more underserved countries. Just because they don't have access to a drug doesn't mean that they shouldn't have access. And really question the use of placebos, which is a drug, no intervention, a fake pill in those groups. And I think that is where I hope things are going. But we did see it in the HIV trials where that's what they had done.
And then can you tell us more about the process of approving, say, animal drug trials to go to human drug trials?
So animal studies are all reviewed by a separate IRB. So they aren't reviewed by human IRB. They are actually also scrutinized pretty extremely as far as what's been done. Same principles of safety, risk benefit to the animal, how they're cared for, who's caring for them, the environment they're in. So they look a little bit more at the environment than a human trial. Going from bench to kind of research, there are kind of 3 phases of drug development. The first is a phase 1, and that's just we're going to try it and make sure that there's no serious harm. The second is a phase 2, and those are usually dose escalating trials where a drug will be started and they are trying to figure out the exact dose that actually has a good side effect benefit profile. And most of those are kind of phase 2, so early on. And a phase 3 trial is really when you get into the randomized, does it work better than standard of care? So there are kind of 3 phases for drugs to go through until they get actually into market.
Wow. And then do you know how long that kind of process would take?
About 5 years.
Wow, 5 years. That's crazy. While we're talking about, all this different kind of research, can we hear more about your research?
Sure. So as Dr. Feller mentioned, I do cardiovascular research. And so a lot of my work has been on looking at different biomarkers that detect heart injury, or looking at how we can risk stratify people to figure out who actually needs additional testing. And that's either from symptoms to protocols to how we can use biomarkers with risk kind of ways to risk stratify to make the most efficient manner of getting the right diagnosis and putting resources to those who need them and not doing stuff to people who don't. And that has been, it's a fun work. It clearly involves working really closely with lab people, so pathologists to cardiologists to emergency physicians. And that's been really kind of beneficial and fun to have that kind of multidisciplinary approach to my work.
I always like to say, Deb, that research is where you find it. We pulled all the charts on all of our heart attacks for 1 year. We had 104 at Parkland ER. And we found that if they arrived by ambulance or arrived by car, that more or less the outcome was about the same. It just took longer to get an EKG done. But Deb, we found that non-English speaking folks were 600% more likely to arrive by car than arrive by EMS. Yep. So we found a social issue and how in the world to deal with that. It's funny that you just turn a corner and you find something very interesting.
Yep.
So Rachel? We have a lot of high schoolers in our program. Would that same, method of reaching out to professors or, researchers be the same for them to get involved in research?
I think most people, especially if they're a college professor, will try to reserve their extra time to work with college students. So getting involved in high school is a little tough, just because there's a lot of people asking everybody for their time, and they're going to probably invest in people who go to their college. I think there are probably some programs, but I think at that level, I think it's really more I just would spend my time on community service and building that kind of arm of your kind of multifaceted personality and experience. I'd probably wait on research until you get to a college, just because that's where all your resources will be, and people will be more willing to kind of and have more time to invest in you.
I think they're just really excited to do research. Are there any consequences for researchers who fake data and publish unfounded results?
Yeah, so it's interesting. So there's 2 approaches. One, the journal will take an approach. And so there have been, and I've been part of, because I'm on editorial boards, looking at some of these kind of fake data or more importantly, copyrighted data or plagiarized data. So we actually have the ability for every manuscript submitted to actually run it through and see if there's matchup from other articles. So we can actually look to see how much things have been plagiarized. We've had a lot of discussions about what percent is a problem, because some words just are the same. But we look for that in manuscripts to make sure they're not plagiarized from others. The fake data is a little harder. Every manuscript that's submitted gets reviewed by, 2 content experts who know the subject, but also a statistician. And so hopefully a lot of those questions about methodology are caught. Usually fake data is tough to glean. And typically that's been found by competitors or other people who are knowledgeable in the field, who say, look, this can't be right. And that's kind of happened in the past.
Awesome. Well, I'm glad that people are always looking out to see like what's incorrect and whatnot. So as a researcher and a doctor, how do you balance both of those hats/roles?
I think balance is in the eye of the beholder. And so I think that there are many who would say I have no balance, and I'm okay with that, because I think I'm fine. My balance is my balance. Research, when you're into it, you love doing it. And so it's not work. It's kind of fun. And I think that balancing my clinical shifts with research really, you kind of go in different phases of your life. When you start out as an attending, if you don't have any funding, you're a big clinical doctor and a little researcher. Until you get funding or get support to do research, that clinical piece decreases and your research piece can increase, but it really is based on funding and protected time to do that work. And when you start research, in most instances, you're going to put a lot of sweat equity in before you get the time to do it, because you've got to show that you can get it done.
Deb, of all the research you've done, what study is one that stands out to you most of a very interesting finding?
I think the one that stands out for me most was Jeff, working with Jeff Klein on the use of TNK for pulmonary emboli, for moderate pulmonary emboli. And it stands out for me most because it was a negative trial, right? It showed that really not much benefit. But that was an interesting study, because we were going to give this clot buster to people with PE. And at my institution, that clot buster was only given in the ICU, and these patients had to be observed. And so the IRB said, this is one of the benefits of being on it, said, look, you can do this study, but you have to observe that patient, just like we would in the ICU. And so on that study, I spent some nights sitting in chairs in hospitals beds, in the patient's hospital rooms, observing them. And one of my most memorable kind of things, I think will probably haunt me for the rest of my life, was I had the major adverse event in one of my patients in that trial, who ended up getting placebo. But it was Christmas Eve. She was enrolled in the trial, and I sat with her in the ICU for 12 hours. And her family had come in, and they had seen her, and her sons had flown in, and it was all a happy reunion. And I went home. And the next morning I went to check on her, and she had passed away. And that was probably one of the hardest patients, because I got to know her, I talked to her, I saw her family, and that was just a hard one. And it's not one I'm going to forget, because it reminded me how crazy that disease is, that it was somebody who was sitting there laughing, and a few hours later was dead. And so I think that was probably one of the most impactful research studies, more because it just highlighted why we need a better treatment, and we just don't have it for that disease.
I have two thoughts. It was funny, about 15 years ago, we thought that by giving a sugar water and potassium solution, this was the immediate trial, to people having a heart attack, that we could nourish the muscle and shrink the size of their heart attacks. And we did the study, and it turned out it didn't do anything, but it was then replaced by the alternative therapy that we all use now, which is get the artery open.
Yep.
The other thing that I've been able to participate with Dr. Idris, of course, with the Resuscitation Outcomes Consortium, is that it was interesting over about 15 years to watch steadily a little bit how we refined how cardiopulmonary resuscitation was done. For example, in the old days, we thought, bag them, give them a lot of air, that must be good. Well, it turns out it's not good. If you over bag them, over ventilate them, in fact, they don't do as well. So it's been interesting to be a part of watching things change with the passing years. Rachel?
So how do you deal with patients who don't believe in research and the studies and results that have been posted?
So they don't believe in the research that's been done.
Mm-hmm.
Patients have the right to make their own determination. And I think you respect it and you explain why you believe in it compared to it. And if they still don't want to participate or don't want the treatment, that's really up to them. And that's really the challenge of being a doctor, is we can't make everyone's decisions. We as a physician, though, have the responsibility to provide them with the information.
That's very great. I think that's a lot of questions that we've had. I think you've been so great about answering all of these amazing questions. Can you go to the next slide, please?
Yep.
And then can you make it full screen?
Yep.
All right. And then
I can make myself fade away.
There we are.
Perfect. Thank you so much. Here's the quiz information. You have until next week, 11/10 at 6:59 p.m. Central Standard Time to do the assessment. It's real easy if you listen. You don't need a Quest-based account to do this. Just enter in the PIN for Find Assessment and enter the password, Derek's, and then it should let you in. If you have any questions and concerns about the assessment, please don't hesitate to email us before the deadline, because we can't do anything about it once the quiz is done. And this information will be sent out on our Instagram, on our website, and in tomorrow's email if you can't see the screen right now. So don't worry, we got you. Dr. Fowler, can you take it away for any closing notes?
Absolutely. Deborah Dirks, what an amazing talk. There were 1,000 kids online listening to you. There will be 5,000 that will hear your talk ultimately on the posting on YouTube. Each of those 5,000 kids, Deb, will become a healthcare provider and see 100,000 patients in their career. 5,000 times 100,000 is 500 million. Tonight, Deb, you touched 500 million lives with your wonderful humanity, your amazing scholarly approach to the world, and the leadership that you've shown. We are deeply grateful, and thank you so much for joining us. Everybody, all 600 of you online, please put "Thank you, Dr. Dirks" into the chat room right now so she can see that, okay? All right, everybody, we're going to wrap this up. Thank you so much for coming. We'll have another exciting talk next week. We're going to be here as long as you keep coming back. And so on behalf of Dr. Dirks, on behalf of the whole working group for the virtual shadowing team, we want to thank you so much for coming and being part of our family, and we wish you a good evening. Good night.